Hello and welcome. This is the 50th Cervical Spine Research Society Annual Meeting, and we're very fortunate to have a great group for case discussions. First of all, I want to thank our annual meeting committee. They did a fantastic job. We hope to catch everyone up in San Diego starting on Wednesday with our in-person visit. I'd like to start today's session. We're very fortunate to have a great group. Heiko Kohler from President of European Cervical Spine Society. We have Dan Riew, who is a past president of the Cervical Spine Research Society, and we're very fortunate to have Dr. Young Q. I'm excited to hear you guys and take it away.
Well, thank you. I'm going to be presenting this coronal plane deformity cervical case. And these are my disclosures. I do get royalties on some products and own some stocks that I purchased. This is a 56-year-old male with a lot of neck pain and arm pain and a coronal deformity. He presents with these x-rays, and you can see this is his flexion extension and oblique x-rays. You can't tell a lot from these x-rays. And likewise from the MRI, it's very difficult other than to say that there is no subaxial spinal cord compression. On the axial images, you could see that there's, again, from C2 all the way down to T1, no real compression of the spinal cord. His CT scan shows that he has complete ankylosis both anteriorly as well as posteriorly in the facet joints from C2 down to about C7. The 3D reconstructed images tell you a lot more. You can see on this that he is indeed ankylosed both in the front and in the back, and he has a coronal plane deformity. And you can see that C2-3 and C3-4 are sort of the apex, 2-3, 3-4, 4-5, and then he seems to straighten out a little bit here, and then he really curves over to one side. It's completely ankylosed in the facet joints here, as you can see on that. And these are clinical pictures. We purposely blur them to disguise them. And he is in a wheelchair. He has bad knees, not because of a cervical spine. He can stand, but he prefers to sit because of knee pain. They won't operate on his knees without taking care of his cervical spine first, obviously. And so what treatment would you do? Would you do this anteriorly or posteriorly? Would you do it as a back, front, back, or a front, back, front? Would you do a PSO, or would you do a Smith-Peterson osteotomy to try to get all of this done? And that's what we can discuss during the second part. What we elected to do was to do this from the front of the neck, and we did anterior osteotomies at multiple levels. And after we do an osteotomy, go all the way through the unsonets bilaterally. We put in standalone devices, and at C7T1 we did an ACDF because that level the patient was not fused. And after doing the anterior, we flipped them posteriorly and put in screws, and then do Smith-Peterson osteotomies to get through the posterior areas that have been fused. And then we put in the rods, and this is his pre-op, and this is his pre-op long cassette view, and this is his post-op. You can see that things have been corrected, and that he has both a sagittal and a coronal plane correction. So thank you very much for allowing me to present this case, and now we'll move on to the discussion.
Daniel, thank you very much to show that nice, interesting case. And this hands me over to the question. When do you decide, this very nice case, you make a segmental correction? You correct it from the front and then from the back, and you're overpowering, which is your technique, from the anterior part. So when do you decide to make segmental approach in comparison to make a realigning approach at the cervical thoracic junction, so to addressing more the plumb line? Is there any rule of thumb you have for these kind of cases?
Yeah, so what I do is I look to see how much correction you can get from just one or two levels. And So if you have the rest of the cervical spine from, say, C2 down to C7 or T1 is relatively straight, and you have one level deformity, which you often have when you have patients with ankylosing spondylitis. They usually are quite straight from C2 down to C7, and they were compensated, and then they sustain a minor trauma that causes a compression fracture at C7, and now they have a chin-on-chest deformity, but it's all based on the fact that C7 is completely wedged, and it could be asymmetrically wedged, in which case their head is tilted down like that. And in that case, it's pretty easy. All you do is, I prefer to take those anteriorly going on the concave, the convex side, and then essentially do an osteotomy at, say, C6-7 or C7-T1, and then correct them anteriorly. And as you say, overpower it, because you can break the posterior neck by just pushing back on the forehead and tilting it to one side, and then putting in, and if you don't get perfect correction, then you just put in a partial fixation like a cage with one screw so that it doesn't pop out when you go in posteriorly and do further correction. And then in the back, if you need it, you do a Smith-Peterson osteotomy and you put in screws. And that's pretty easy. But in a case like this patient, they've got multi-level kyphoscoliosis, and while you can take it and tilt it all with one level, you're then really doing a lot of correction at just one level to try to get that to straighten out. And that's when I think you're more likely to pull on those nerve roots on the concave side, exactly as you said in your talk. Whereas if you do segmental correction gently at each level, while the whole brachial plexus may be coming over, each individual nerve root is getting stretched just a little bit. So I think you get a better correction overall, and you end up with less tug on each of the nerve roots. And doing an anterior osteotomy, as Themi showed in his anterior osteotomy, is like doing an ACDF. It doesn't take much longer than doing an ACDF. You just protect the arteries with a Penfield 4 and a 2 on one side and just burr through until you get to the back, and then you put segmental fixation and put one screw, then you move on to the next level. So you can do that relatively quickly, especially if you don't have to do a lot of decompression, as I didn't have to do in this patient. And then it's relatively easy to get an overall well-balanced correction.
Very good.
Daniel.
Mindful points.
Daniel, so excellent results, but heavy surgery. It seems the driver of spine deformity is located at C7. So I'm wondering if C7 PSO by posterior only approach is enough. Maybe the correct clinical results will not be as excellent as used, but it's not heavy surgery.
Yeah, so I completely agree. You can do this all from behind, and you can do a pedicle subtraction osteotomy asymmetrically, so that on the convex side, you take out the entire pedicle, do partial vertebrectomy. On the left side, you just need a Smith-Peterson osteotomy. You don't need to do a pedicle subtraction. And then you can tilt it and bring it back and get the correction that you need. What we found actually was when we compared my results with a pedicle subtraction osteotomy versus an anterior posterior, that with an anterior posterior osteotomy, the average blood loss was somewhere around 250 cc's, I think it was, or less. With a pedicle subtraction osteotomy in my hands, it was more than that. Also, with a pedicle subtraction osteotomy, bear in mind, I haven't done one now in over 10 years, but when I was doing it before, it would take me over 5 hours to do a pedicle subtraction osteotomy and fixation from, say, skull down to about T3 or T4. Whereas the anterior posterior osteotomy took me less time, and it had resulted in much lower blood loss. So in my hands, I find that a front back takes less time and is less bloody than doing a PSO at, but as I tell people, it's what you feel comfortable with. And if you can do a PSO, you know, and do that in less time, then it works much better for your patients.
Thank you very much for this. One quick point from Themi, please.
Dana, you've shown such elegant videos of your anterior osteotomy technique, where you also slowly, gradually correct the spine by removing towels or sheets. from behind the head and applying some pressure on the forehead. Do you do that in these cases where you're still going to do a posterior and as part of an anterior posterior, or are you just going to go in the back and do the complete resection of the facet joints and do the correction at the back?
No, I do that in all of these cases so that the head is essentially floating in the air. Then I put sheets underneath and take it out one at a time. That's a gentle correction. And if the head is tilted, then I can push on the head and then push backwards to get the correction, because it breaks right in the facet joint. And that way, what you're doing is you're opening up the foramen, as opposed to with a PSO, you're shortening the column and closing down the foramen. You got to remove the pedicle so that you don't trap that nerve root. And it's a blinded pedicle. When you're doing a PSO, it's a blinded resection of the vertebra, whereas when you're doing it in the front, it's complete visualization. The root becomes very evident. And so I think in my hands, the neurologic deficit rate, I can't prove that because we haven't had a significant neurologic compression rate, but I think it's easier and less likely to cause a significant neurologic deficit.
Very nice points from both sides to give really a few anterior and posterior the options.